everyone, it's Nurse Sarah, and in this video I'm going to go over pediatric nursing NCLEX questions and answers. So let's get started. Our question says you're assessing a 2-month-old infant. Which finding is a normal milestone that should be reached by this infant at this age? So the big thing with this question is that we are dealing with an infant that is 2 months old, so a very young child. And we need to think back to all those growth and development milestones. Which milestone should this infant be at 2 months? So what we can do is just really a process of elimination. With the infant can set up with support, that happens a little bit later on because that requires a lot of muscles to be able to do that, even though they're having support. That typically happens around 6 months of age, so mark that off. B, the infant smiles at its parents. That's looking very promising. That's a relatively easy thing to do, so let's keep that in the back of our mind. C, the infant passes a rattle from one hand to another. That takes some effort to do so. Around 2 months, they can start to hold objects like a rattle, but actually taking the rattle and passing it from one hand to another takes a little bit more development, typically around 6 months, so we're going to mark that off. And then D, the infant is afraid of strangers. That is when the stranger anxiety starts to happen in some children. That typically happens around 6 months as well. So we're left with B, and that is the most appropriate milestone that this infant should reach at about 2 months. Next, we have an 8-month-old that is hospitalized. What nursing intervention will you include in their plan of care? So here we have an 8-month-old. They are hospitalized. So when you see that, you want to start thinking, okay, what do I do for a child at this age when they're in the hospital? When they're in the hospital, things can change, especially it affects toddlers, preschoolers, and teenagers because they're more aware, and hospitalization isn't good. So as nurses, we have to do things to help accommodate them based on their age group. So we know we're still dealing with an infant. They're a little bit older than our previous question, which was 2 months. So again, it's just really process of elimination. You're going to look at each option and you're going to say, okay, is this appropriate for this child at this age in this situation? So A, separate the infant and parent during procedures. This, based on this child's age, you definitely wouldn't want to do that. If anything, this would increase their anxiety being away from their parents. Now, as the child gets older, let's say an older school-age child or teenager, it's okay to separate the parent and the child because a lot of times they want privacy, especially that teenager. But at 8 months, this is not a good option, so we're going to X that out. B, maintain the infant's daily rituals and routines. This is more for an older child, more of the toddler age. They get really fixated, some toddlers get really fixated on rituals and routines. And if you break those, it can cause them to regress. Our 8-month-old just isn't there yet, but if they were older, that would be a great thing, but they're not, so we're going to X that out. And then C, allow the infant to examine equipment before usage. 8 months, they're not really cognitively aware. Yes, they could maybe play with some equipment that's safe to give them something to fiddle with their hands, but that is not really the greatest answer that we're looking for because they are not old enough really to play yet with that. That's more toddler, school age, preschooler. And then D, so I wonder what our answer is. It's D since we've eliminated everything else. But why is this the best answer? Maintain the same nursing staff during each shift. What does that achieve? If this child is having the same staff provide care to them during day shift and night shift, that is going to get that child used to those caregivers and decrease their anxiety. Because it can be as early as 5 months, but 6 months and onward, stranger anxiety starts to develop. So whenever that child sees someone they don't recognize, they tense up, they get anxiety, they get scared, they don't want to be touched. So this would hopefully help alleviate that from happening, and that's why it's our best answer. Next, we're told we have an infant that weighed 8 pounds at birth. How many pounds should the infant weigh at 6 months? This question is pretty much a straightforward question, and it's relatively easy if you have memorized how the weight should fluctuate of an infant based on their birth weight to 6 months in a year. Those are sort of big milestones, what we're looking at whenever the patient's coming in for their growth measurements. And what you want to remember is that at 6 months, that weight should double compared to their birth weight. And then at 12 months, a year, their weight should triple based on their birth weight. So all you have to do is multiply, and they're wanting to know 6 months. So what we're going to do is double 8. 8 doubled, 8 times 2 is 16, so our answer is D. Now, let's say that it said, what should their birth weight be in a year? Well, we know it should triple. So 8 times 3 is 24. It would be 8, but here our answer is D. This question says, the parents of a 3-year-old bring their child to the ER. The parents report the child suddenly developed a fever overnight and has had issues swallowing, which has led to excessive drooling. In addition, the parents explain that the child complains of a sore throat, and it is hard to understand the child's speech because her voice is muffled. Based on this information, your next nursing actions will be select all that apply. When you look at this question, some things that should be jumping out at you are the patient's signs and symptoms. So you want to look at those signs and symptoms and look at the child's age and say, okay, based on this child's age, these signs and symptoms I'm seeing, what are they probably experiencing? Because around this age, some big childhood illnesses can happen. So we see that the child has developed a fever overnight. They have had issues swallowing, which has led them to experience excessive drooling. So we know something's happening up here in our upper airway. And the parents tell us that the child complains of a sore throat. And it's hard to understand the child's speech because their voice is muffled. So definitely we have some inflammation, something going on up here. Thinking back to pediatric nursing, what are some things that can affect the child and have these signs and symptoms? I'm thinking epiglottitis. So you want to think back to what is epiglottitis? Well, it is inflammation of the epiglottis. And think about what your epiglottis does. Well, this is a hinged piece of cartilage, and what it does is it closes during swallowing so it can prevent aspiration. And if we get this structure inflamed, we can seal off our airway, and we don't want that to happen. And epiglottitis tends to be most common in children between the ages of 2 to 5. And it can affect adults, but it happens more in the pediatric population. And one thing we have to help prevent epiglottitis is that there is a vaccine, because one of the most common causes of epiglottitis is caused by the bacteria known as Haemophilus influenza type B. Now, it can also be caused by other bacteria like Streptococcus pneumoniae, but in children it's mostly the Haemophilus influenza type B. And there is a vaccine that can be given. It's part of the childhood vaccine schedule that can help prevent these cases. So you want to be able to make the connection between that, because some questions could come about that vaccine and when it's given. So let me review that with you real fast. So you want to give that vaccine 2 months, 4 months, 6 months, and 12 to 15 months, and that helps prevent cases of epiglottitis. So a big thing with epiglottitis that you want to remember for exams is that as a nurse, you do not want to put anything in that patient's mouth. No tongue blades, no oral thermometers. You don't want to do a throat culture, because you can block off that airway by causing a spasm to occur. So whenever you're looking at these options, you want to make sure that you're not going to be doing a nursing action that would promote those things that we just covered. So assessing a child's temperature orally, not a good job, because you're going to go in the mouth. There's other ways to assess it. So we'd X that off. That's not going to be our next nursing action. B, obtaining a throat culture. No, that requires we go in the mouth. C, count the patient's respirations. That's good. We want to make sure that their breathing rate is appropriate, so we'll do that. So that's one of our answers. And then D, assess the child's throat for tonsillar exudate. Again, that requires that we go in that mouth and we have to disturb their potential airway. So we wouldn't want to do that. And then E, keep the patient NPO, which is nothing by mouth. So we would want to include this in a nursing action. So E would also be the answer along with C, because this patient, again, is at risk for airway obstruction. So until this inflammation decreases, we want to keep them from having any food. Plus, the patient may require other types of procedures where they would not need to be able to have food in their system at this time. Now, as a side note, you would also want to promote activities that decrease anxiety or agitation. You wouldn't want to separate the child from their parents because that's going to increase separation anxiety. They're sick. They're not in the mood to be away from people and around strangers. So keep that in mind whenever answering questions like this. This question says the healthcare provider orders a child an oral medication of 200 milligrams by mouth every 8 hours. The child weighs 50 pounds. The safe dose range for this medication is 2 to 20 milligrams per kilogram per dose. What is the safe dose range for this child? Fill in the blank. So here we have a dosage calculation problem that we need to work out. To solve this problem, you've got to do a little math, and I'm going to use dimensional analysis to do this. So we're solving for the safe dose range. To solve, we need to know the safe dose range, which is given to us here. On the low side, the patient can have 2 milligrams per kilogram per dose, and on the high side, they can have up to 20 milligrams per kilogram per dose. And we also need to know the patient's weight, which is 50 pounds. Right here, we're not going to need this information at this time because we're just solving for the safe dose range. But if it was asking us, is this a safe dose, then we would need to know. So technically, that's just a distractor. First, what I'm going to do is I'm going to solve for the low part of the safe dose by using this. So first thing I want to do is I want to put in the patient's weight, which is 50 pounds. And we got one child. And I need to convert these pounds to kilograms. So we know from the metric table, there's 2.2 pounds in 1 kilogram, and that cancels out pounds. Now what we need to plug in is our dosage. So we're going to do 2 first. So the patient, for every kilogram they weigh, they can have 2 milligrams per dose. That cancels out kilograms. Now we're ready to multiply everything at the top and everything at the bottom. When we multiply all that out, we get 100 on the top, we get 2.2 on the bottom. And then when we divide that, we get 45.45 repeating, and we're going to round to the nearest tenth, which gives us 45.5 milligrams per dose. And that is the low part of this. Now we need to solve for the high range. Again, we're going to just repeat this, but plug in the 20. So our patient weighs 50 pounds, one child. We know from the metric table, 2.2 pounds equals 1 kilogram. That cancels out pounds. And we're going to plug in our safe dose range. We know that for every kilogram the patient weighs, they can have up to 20 milligrams per dose. Cancels out kilograms. We're going to multiply everything at the top and bottom and then divide. When we do that, we get 1,000 at the top. We get 2.2 at the bottom. When we divide that, we get 454.54 repeating. We're going to round to the nearest tenth. We get 454.5 milligrams per dose. So 45.5 to 454.5 milligrams per dose is our safe dose range. And if this problem did ask us if this was a safe dose, the answer would be yes, because they're ordered 200 milligrams by mouth for each dose. Next, we have a parent who has a question about the rotavirus vaccine and when it is administered, and we're supposed to complete the statement below. So this is one of those alternate format questions where we have a drop-down box and we have to select the correct answer so that statement is a correct statement. So it's one of those closed type questions. Okay, so it says you know that blank doses, so either 2, 3, 4, 6, are administered to the patient over a period of time, and the last dose of the rotavirus vaccine is given at 3 months, 4 months, 4 to 6 years, or 6 months. Thinking back to the rotavirus, we know that this can be a dangerous illness for young children. That's who it tends to affect, and it's a GI illness that will cause them extreme diarrhea. And it's dangerous particularly at these young ages because it can quickly lead to acid-base imbalances, electrolyte imbalances, which could lead to death. So it's important that they receive this vaccine. Now, when do they get it? Well, since they're young, we want to give it to them young. It is given in 3 doses. They're going to get it at 2 months, 4 months, and 6 months, and then they're done. So we just have to fill it in with that. So we know that 3 doses are administered to the patient over a period of time, and the last dose of this vaccine is given at 6 months. Now, as a side note, I know that this pediatric vaccine schedule can be really overwhelming because there's a lot of vaccines that these children receive from 0 to 6 years, and as nurses, we have to be familiar with these vaccines. So I have a video up here. It's a comprehensive video where I break down each month of what the child has to receive and give you some ways on how to remember that information. Plus, I break down and let you see the patterns about how it really overlaps, because a lot of times these vaccines are going to be given at 2 months, but they may repeat themselves at 4 and 6 months. So if you want to watch that, you can check it out up there. Here we're told in a 4-month-old infant, you assess the Babinski reflex. What is the appropriate response in an infant at this age? To answer this question, you've got to be familiar with those infant reflexes. So I have a whole video up here where I show you all the infant reflexes you got to remember. It's demonstrated in a real infant, and you want to be familiar with how to get a response from that reflex and when that reflex disappears. So thinking back to Babinski reflex, this reflex typically goes away about 12 months, a year. So here at 4 months, our infant should have it. And what you want to know is how to get that reflex to show itself in a sense. So here you're going to see some footage, and note in the footage, when the foot is stroked from the heel upward, the outer part of the foot and the big toe dorsiflexes. So dorsiflexes whenever they bend back, and the other toes fan or spread out. And this is a normal response and what we expect to see. So whenever you look at all these options, you got a lot of flexing. You got plantar flexing, dorsiflexing, curling downward, everything. So you want to think back to anatomy and those terms and what you should be seeing here in this 4-month-old infant. So based on the footage we just seen and what this infant should present like, it should be C. The big toe dorsiflexes and the other toes spread outward. Our next question says, during auscultation of heart sounds on a newborn, you auscultate a continuous machinery-like murmur. You auscultate it at the left upper sternal border and note it is heard during diastole and systole. This assessment finding is typically present in what condition? When you look at this question, one thing that should be jumping out at you is that weird thing that was detected on auscultation, which we're told was a continuous machinery-like murmur. So whenever a newborn is born, one thing the nurse does is listen to the heart sounds, and we're trying to detect if we hear anything abnormal, because that could point to a potential congenital heart defect. So whenever you're studying these congenital heart defects, pay attention to the assessment findings that are unique to that specific defect, because exams love to ask about these hallmark little signs and symptoms that will present with each, like this question here. So let's take it one by one and analyze which one will have a continuous machinery-like murmur. So first up is patent ductus arteriosus. So this is a congenital heart defect where our ductus arteriosus has not closed off. So this is a structure that's in the fetus that connects the aorta and the pulmonary artery, and it works for the fetal heart. But whenever they're born, they really don't need this structure anymore. So within 3 days, this structure will close off. Now, unfortunately, sometimes this structure doesn't close off in a newborn. So what's going to happen is that now you're going to have this fresh oxygenated blood just pouring into that pulmonary artery. And we know from heart blood flow that the pulmonary artery is supposed to take deoxygenated blood to the lungs to become oxygenated, send it back through the pulmonary veins into the heart, and then it hits the left side of the heart, goes through the body, and we get fresh oxygenated blood. But here in this case, what's happening is that we have a little, in a sense, water hose, like I like to think of it, connecting to our pulmonary artery that's just adding this extra blood that's oxygenated. So we have increased blood flow that's going from our pulmonary artery to our lungs. And this is going to stress our lungs out because it's going to increase the amount of blood volume going to the lungs, which increases pressure and can lead to pulmonary hypertension. Now, because we have that little water hose connecting our aorta to our pulmonary artery in this newborn who hasn't closed this structure off, we can detect that with a stethoscope if it's large enough. So just think about it. If you have extra blood volume pouring into a structure, you're going to hear this loud noise that can be described as a continuous machinery like murmur that you can hear during diastole and systole. Plus, just think about where the structure would be located. It's going to be located at the left upper sternal border. Now, why is B not the answer? Well, let's quickly review Tetralogy of Fallot. So with this, a big thing that you're going to see with it are TET spells, T-E-T. And these are spells where the patient is going to become bluish at times. They're going to experience cyanosis, especially with times of increased activity like crying, eating. And with that, you're going to hear a harsh systolic murmur. And then with C, an atrial septal defect, let the name help you. We know that between the right and left atrium, we have a wall, the septal wall. And what can happen is you get a hole in between that wall, and the size of the hole can really vary, but it typically doesn't start to show signs and symptoms until later on in childhood or even adulthood. And with this, depending on the size of the hole, you're going to hear a mid-systolic murmur at the second intercostal space at that left upper sternal border. And then lastly, transposition of the great vessels. So with this congenital heart defect, patients are going to have severe cyanosis that is persistent. And the reason for that is because we have transposed, hence switched, two of our great vessels. We have switched the aorta and the pulmonary artery. So the aorta is now coming off the right side of the heart, and it's delivering deoxygenated blood to the body, where normally the aorta should be coming off the left side of the heart and delivering oxygenated blood to the body. And then we have the pulmonary artery over there on the left side of the heart that is just sending oxygenated blood back to the lungs, and it's just staying over there. So you have the right side doing its own circulation and then the left side doing its own circulation. Now, a lot of times what can happen with this congenital heart defect is that the child will also have other defects where they will have a hole in their ventricular septum, or they will have a hole in the atrial septum. And that will allow that blood to mix, so we're actually getting oxygenated blood with deoxygenated blood. But in severe cases, you just have the right side doing its own thing and the left side doing its own thing. So that will cause that severe cyanosis because we're not getting oxygenated blood to the body. Unfortunately, our aorta is delivering deoxygenated blood. So again, A is the answer. Next up, we have a 12-month-old receiving a series of vaccinations, which include the Hepatitis A vaccine. When should the child receive the second dose of this vaccine? So here we have another vaccine schedule question, which are big questions that pediatric exams love to ask you. And we're told that this child is 1 year old, hence 12 months. So they're getting the Hepatitis A along with a bunch of other vaccines. But the question specifically wants to know about this Hepatitis A vaccine. So thinking back to the Hepatitis A vaccine, we know that it's given in 2 doses, and those doses are given 6 months apart. So typically it's given at the 1 year visit, which is the 12-month visit, and it's going to be given 6 months later. So because our child is getting it at 12 months, we just add 6 months to that, which puts us at 18 months. So the child should get the next dose after 18-month visit. So the answer would be B. Next, we're told you need to start an IV on a 4-year-old. Select all the appropriate interventions to perform before starting the IV to help the preschooler cope with this procedure. So we're going to have more than one answer. When answering this question, you want to think about what's appropriate for a 4-year-old. So a 4-year-old falls within that preschool age range. So as we go through these options, we're going to say, is this something that would be good for a 4-year-old? And if it's not, we won't select it. So let's look at A. Let the child know that at 9 a.m. you will be starting an IV. Okay, preschoolers, do they understand time? If you tell them at 8 o'clock, we're going to do this. No, majority of preschoolers do not understand that. They don't have that cognitive ability to understand time. So it's best to tell them, for instance, we're going to start your IV after breakfast. They know what breakfast is, so they know once this is done, I can do that, rather than actually giving them a time. So we won't select that. Next, B, be honest with the child about what to expect with starting the IV. Yes, we would want to do this, so we would select this. The reason for this is because we want to be truthful with the child. We don't want to tell them something that's not true. Starting an IV does hurt. It's not the most comfortable thing in the world. So we're establishing trust. We want them to trust us and know that we're going to be honest with them. So yes. Then C, have a doll available that the child can start an IV on. Yes, this is a great teaching tool for this age group because they can see the equipment, they can see what exactly is going to happen to them, because sometimes their imaginations run wild and they think they may be losing an arm or a leg, and just letting them know how it's going to be will alleviate a lot of anxiety. D, give the patient privacy and direct the patients to the waiting room while the IV is started. No, we would not want to do this because having the parents there with the child helps alleviate the child's anxiety, knowing that their caregivers are present. So we wouldn't want to do that. It would make things worse. And then E, encourage and answer all the child's questions before starting the IV. Yes, we would want to do this, and probably this child will have a lot of questions, and just answering their questions will help hopefully alleviate some of that anxiety. And again, letting them participate with the doll will help as well. The next question says, when considering Erikson's stages of psychosocial development for a 3-year-old, which action below would potentially hinder a child's development? When answering this question, we got to think back to all those stages of Erikson's stages of psychosocial development. And here we have a 3-year-old. So they are a preschooler, and we know that based on Erikson's stages that they are in that initiative versus guilt stage. So the whole goal of that stage is helping that child venture out, develop confidence, become independent, so they can develop a sense of purpose. Because if they can't achieve that, they will be not confident and they can experience guilt and question themselves. So let's look at the options that's not really going to help that child be able to develop that sense of purpose, because that's where we're trying to get this child. Okay, A, giving the child freedom to try new things. That's great. That's going to instill confidence, allow them to make choices and decisions. So that would be good. We'll keep that. B, offering options of play that are imaginary. Children at this preschool age, they love to play imaginary games. That helps them develop not only socially, but helps them to venture out and to be independent in control of their own little environment that they have created themselves. So B's good. C, accepting reasonable choices made by the child. That again is another good choice. That's going to instill confidence in the child as we accept their choices, letting them know, hey, you're making a good choice. Yes, you can do that. And it's giving them a sense of purpose. And then lastly, D, making choices and decisions for the child. So obviously that's our answer because it's the only thing left, but how does that hinder a child's development? So we're trying to get them to a sense of purpose, and making choices and decisions for the child will limit their ability to venture out and to be independent. So within reason, we need to give them ample opportunity to make decisions and choices, because that's going to make them more confident and it'll give them a sense of purpose, and they're not going to struggle with guilt as much. Next, we're told we have a 6-year-old who is hospitalized for the treatment of a broken arm. The child is becoming restless and bored. The nurse asks the child if they would like to do an activity. Which activity below would be appropriate for the nurse to suggest to the child? When we answer this question and try to determine, okay, which activity is going to be best for this patient, there's 2 things we got to take into consideration. Number 1, their age range. They're a school-age child. They're on that young school-age child spectrum. So we need to think about things that are appropriate for them, that they're going to find fun and be able to do. And then we're dealing with a broken arm, so they're going to be limited in their mobility. So let's just do the process of elimination. A, stacking blocks. Is this going to be something that this 6-year-old's going to find fun? Well, probably not. Now, if we're dealing with a toddler or a preschooler, yeah, they're going to like stacking blocks. But a 6-year-old, they've been there, done that, probably not going to find that as the funnest thing in the world. And plus they have a broken arm, so that could hinder it. So let's look at our other options. B, writing poems. So on the surface, that might be good, but let's think back to our 6-year-old. At the age of 6, a lot of children are just now learning how to write. And they're especially just learning how to spell. So they're not really there in putting complete sentences together, complete thoughts together, just developmentally. They're not able to do that just yet, most children. Now, we do have some prodigies out there that can do that. So B, we're going to eliminate for now because that would be more appropriate for the older school age child to into the adolescent. Okay, and then C, watching a movie. Okay, I'm liking that one because number one, we don't have to use our arms. And again, that's back with the writing the poems. They're going to have to use their hand. Hopefully they didn't break the arm of the hand that can write. But anyways, back to C, watching a movie that doesn't require their arms. They can sit there, be entertained mentally. So we'll keep that one. And then the last one, D, playing a card game. Playing a card game may be okay, but I'm thinking back to that broken arm holding the card. So between C and D, our best option is C, watching a movie. The next question says, the nurse is developing a plan of care to help the school-aged child and their caregiver implement diet changes to help decrease the child's obesity risk. Which intervention below should be avoided? So here we want to pick an option that should be avoided, that we don't want to include in our plan of care for something that they should implement in their diet changes. So let's analyze them. A, include the family members with setting weight and food goals. This is actually a positive thing. If you get the family involved in setting their own weight goals and everyone has their own goals for food, that's a great way to be successful in implementing diet changes. So we definitely want to keep that one. B, using a reward system that includes food rewards. Let's think about that for a moment. Reward systems are great, but do we want food to be our reward for achieving diet changes? I don't know. Let's look at our other options before we decide. C, substitute the child's favorite food with healthier food options. That seems like a good positive thing because there's a lot of fruits out there that taste almost just like candy, but it's actually real healthy things and contains healthy nutrients rather than a candy bar. So we will definitely keep that. And then D, consider team sports for the child. That is an easy one because team sports is going to get the child physically active. They're going to be with other children, socializing, and that seems like a good option. So going back to B, that would be our answer. We wouldn't want to do that. And why is that? Reward systems are good, but it depends on what your reward is. So whenever you are using food as a reward, especially in where you're trying to implement diet changes, that's going to teach the child to associate food with rewards, and we don't want that to be associated. So a reward system could be used, but use something as a reward other than food. Next is, what interventions below should the nurse implement to help the adolescent cope with prolonged hospitalization? Select all that apply. When you see this question and it has an adolescent who is in the hospital and it looks like for a long time, there's some things that should be jumping out at you that's really important for them during their time of development. One is privacy. Another thing is maintaining their identity, and then another thing is making sure that they are being able to socialize and not lose contact with their friends, because all that together is very important. So we want to select options that promote that for the teenager. So A, allowing the patient to wear their own clothes. If this is possible, yes, absolutely let them wear their own clothes. That allows them to express themselves in their dress. That's how many teenagers express their identity, is through the clothes that they wear. B, reassure the patient that procedures are not meant as punishment. The adolescent is very aware of this. This is more for our younger children, more like getting in the toddler preschool territory. Sometimes I think when bad things happen is because they're being punished. So this would not be appropriate for the teenager because they understand this. C, restrict visitors to family members. Generally, for most adolescents, this is not going to be the case because they want to be able to socialize with their friends, their peers, making sure that they're not forgot, they're still part of the group. So if possible, we would want to allow their friends to be able to come and visit. D, encourage the patient to participate in recreational room activities. D, yes, that would definitely be an option, because if the teenager can. That gets them exposed to other teenagers who are there on the unit, being able to socialize and converse with them and form relationships. Again, big deal for the teenager. This question says, while feeding a 3-month-old infant who has Tetralogy of Fallot, you notice the infant's skin begins to turn a bluish tint and the breathing rate has increased. Your immediate nursing action is to A, continue feeding the infant and place the infant on oxygen. B, stop feeding the infant and provide suction. C, stop feeding the infant and place the infant in the knee to chest position and administer oxygen. Or D, assess the infant's heart rate and rhythm. In this question, our patient has a congenital heart defect known as Tetralogy of Fallot, and they're having the classic signs and symptoms that presents with this heart defect known as a Tet spell, where the skin is turning cyanotic. So based on this, what are we going to do for the patient to help relieve this Tet spell? So to answer that, you have to think back to what Tetralogy of Fallot is. This is where you have 4 major structural abnormalities that leads to a decrease in pulmonary blood flow. So that's why you're going to see that cyanosis in the patient. And to help you remember those 4 structural defects, remember the word RAPS. You're going to have right ventricular hypertrophy, which your right ventricle is going to be thickened and large. You're going to have aorta displacement, where the aorta is not where it's supposed to be. You're also going to have pulmonary stenosis, where the pulmonary valve is going to be narrow. And then you're also going to have septal defects, particularly ventricular defects, where you have a hole in between that wall of the ventricles. So whenever you have all these 4 abnormalities together, you're going to have, as you can see, a decrease in pulmonary blood flow. So you're going to have this abnormal shunting of blood. So when the infant cries, they eat, they do any type of activity that taxes the heart, that decreases the heart's ability to provide oxygenation, and they get this Tet spell. So the nurse can place the child in what's called a knee to chest position. Whenever they do this, this increases systemic vascular resistance, and this helps reduce that right to left shunting that's occurring, and that is going to improve the oxygenation. So the answer with this is C. You would want to stop feeding the infant because the activity of feeding is increasing the demands on the heart, which right now we have decreased pulmonary blood flow. So we would stop that. We place them in that knee to chest position and give them oxygen. So anytime you see Tetralogy of Fallot, Tet spell, think knee to chest position, because that's going to improve oxygenation. Okay, so that wraps up this video over pediatric nursing NCLEX questions and answers. And if you'd like to watch more videos in this series, you can access the link in the description below.